fact, ACOs and health plans today are realize that SDoH is driving cost and is affecting poor health outcomes. But a lack of data capture at a patient level is really one of the main reasons why they're not able to really implement a robust SDoH strategy. Here at Arcadia, we had the ability to really get to that data capture at a patient level. Initially we did a pilot POC analysis across multiple of our customers to really see which are the two main areas how we can capture SDoH information. For example, right here, we looked at housing insecurity as one of our main SDoH factors, and we found that around 65% of those housing insecure populations across 4 customers were really coming in from assessment data. And ICD coding, which is readily available to everyone through claims, contributes to only 35% of identification at a patient level. So this really tells us there's a lot more potential in really leveraging those assessments above and beyond what ICD coding and claims can tell us. And that's where Arcadia comes in with their robust data set knowledge and data set capabilities and helps you identify that level of granularity. Furthermore, we did another POC analysis for our non-for-profit customer in the Pacific Northwest. This customer had incentives in place for doing ICD coding through their providers. But even then, they saw a really big uptick, around 11,000 additional patients that they could identify using a prepared survey that they were feeding into Arcadia as well. For certain categories like employment insecurity, identification through ICDs were very low compared to identification through assessments. And this really hones into the fact that we can leverage more than just ICD codes when it comes to identifying SDoH at a patient level. So what's the Arcadia approach to really address this issue? Because we have a rich data set, we can actually leverage all of these data sources to come up with a robust, clean patient-level registry around our SDoH population. We have the ability to leverage clinical assessments right out of the EHR or point of care. We also have the ability to design our own assessments or feed in assessments to the Arcadia Care Management product and use those assessments to map questions and answers to SDoH concepts. And lastly, we also have the ability to map ICD codes to each of those SDoH concepts. All of these data sources feed into a single patient-level registry, which can then feed into our database around SDoH, which also in turn feeds into the SDoH dashboard, which lets you do very cool things around like geo-analysis, looking at outcomes, monitoring outcomes metrics, and looking at demographics on a map on a patient level, and all that cool stuff in a dashboard form. And this is what we're actually getting to. Once you have identified the right patients, this is where a lot of organizations are struggling to really define impact for those populations. Once we have figured out identifying SDoH on a patient level, we can do these kind of analysis to really leverage and answer the question is, why is SDoH important as of today? This metric really shows you chronic condition prevalence differences between an SDoH population versus a non-SDoH population. For example, diabetes prevalence. You can see for economic insecure populations, the prevalence of diabetes is around 24%. But when you compare it to a non-SDoH population, it's at 7.5%. That's a huge gap when it comes to a chronic condition like diabetes. Similarly, for COPD, housing insecure populations are prevalent at 20.8% compared to a non-SDoH population at 4.3%. So these are really drastic numbers to really, again, hone in on the fact that addressing SDoH is really important today. And these kind of analysis can be done once we have a robust data capture strategy on a patient level. Furthermore, in terms of cost and utilization, we found out that members with SDoH are 2 times more likely to be admitted to the readmitted within 30 days of discharge. Members with housing concern tend to visit the ER 5 times more than people without. And also in terms of PMPM, members with social adversities have 6 times higher PMPM than people without. So these are like really drastic numbers which you can really leverage once you have the data identification on a patient level and really develop, show impact of these members that will justify a financial investment in a SDoH strategy. That's all I have for you guys today. Any questions I can answer right now? All right. That was me. Thank you. Thank you for listening in. Have a good one.
Thanks for tuning in to Byte-Sized Insights. Please visit arcadia.io to explore more of these topics, or check out our other podcasts on data science and healthcare.